Welcome back to Sports Medicine on Tap. My name is Brandon O'Lyon. I'm sitting at Neck of the Woods Brewing Company with my good friend, Dr. Frey, and our new guest, Dr. Webner. Gentlemen, how are we doing tonight?
Spectacular.
Doing great.
Yeah.
So we're revisiting a little topic tonight,
Yeah.
kind of old news, if you will, in a sense. We tried to line this up probably a month ago with Dr. Webner and everything, and then
You got sick?
I got sick, and then last week we tried.
I went away.
Yeah.
Then I got sick.
Then you got sick, and so now we're reconvening and bringing it all back.
Yeah.
So before we go ahead and take a deep dive in tonight, we just want to give a quick shout out to one of our sponsors, Virtua Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip to yard work back and laptop wrist. Guess what? They have a doc for that. So find the right specialist for you at virtua.org/ortho.
So I want to say, I feel like we are building at Virtua Reconstructive Orthopedics like unbelievable, really primary care or non-operative sports medicine program, right? Like it really truly is. Dr. Webner is one of you're the newest addition, I guess, to that. To this group. A little bit about Dr. Webner. Went to undergraduate at Tufts. Got a little connection there. There at Tufts.
We have talked about Tufts before, that's for sure.
That's right. Yeah, and then med school at Sackler Medical School in Tel Aviv. Went to UPenn for his residency, family medicine residency program before doing the sports medicine fellowship program at Crozier Chester. Then went on to become assistant program director, then team physician for the Philadelphia Union since its inception.
Yes.
Before its inception.
Yeah.
Right.
A few months before, right.
And then team doc for Widener University, vice president for Delaware Valley Society of Sports Medicine, and treasurer for the Professional Soccer Physicians Society.
Correct. That's one of our MLS physicians
programs.
Yeah.
So it goes on and on and on.
Yeah.
Yeah. Looking forward
All
to
fun stuff, though. All fun stuff.
Sports medicine fellowship program with us. I mean,
Hopefully
we have
one
some
day
incredible firepower here at this point. It's really amazing,
Well, certainly welcome. Thanks for being flexible with our rescheduling a few times to get you on. So that's really awesome.
Yeah, thank you, man.
You have to thank my wife, not me.
Yeah.
The master of the schedule.
Also,
right?
sports medicine. Yeah,
yes.
Yeah.
Also a sports medicine physician. Correct.
Could have had you both on. It would be a whole family ordeal, right?
Shout out to Trisha Beatty Harris Sports Medicine.
There you go.
All right.
So tonight we're going to take a little dive into a recent topic of deep vein thrombosis in the NBA.
Yeah.
As mentioned before, about a month or so ago, one of the big names in the NBA, Victor Wembanyama, went down with was reported as a DVT in his right shoulder back in February 20th.
Strange.
And shortly after that, he was reported to be out for the season. And then, we tried to set that up. And then the week after, we got sick, whatever. And then, like with most things, when it's not super current, we kind of shelf the idea and we kind of revisit it later.
And then Dame Lillard appears.
Damian Lillard. Yes. I got the text message, I think, the night we recorded our last episode, and I screenshot it, sent it. I said, let's get Dr. Webner back on the schedule and let's figure this one out.
It's current again.
It's current. And so now we're back, and just a week and a half, 2 weeks ago, I think Damian Lillard went down with was a diagnosed DVT in his right calf.
Yeah. Before we get into that, did you watch last night?
The basketball? Of
course.
Yeah. I watched a little bit of it.
Yeah. Are you a fan? Do you watch NCAA?
Yeah, I'm a fan.
Yeah.
Sure.
I caught the last 2 minutes. I watched the
Even though
best
my
part.
favorite was out, but
Yeah. Who's your favorite?
I wanted Duke to win.
Yeah.
Most
people.
I'm not a huge Duke fan, but I clearly, I don't want to say clearly, but my opinion, the best team.
Yeah.
Their best team in the last 25 years.
Correct.
They were dominant. And
so good. Right.
And Florida, they're pretty happy that Houston beat them.
Got them, and then Florida just got Houston.
I won the pool.
You did? Oh,
I
congratulations.
did, because I didn't really watch a whole lot of basketball this year, and that sets you up to win it. Yeah.
I mean, that really does.
I know. Dumb luck, man. Dumb luck.
That's
four first seeds.
Yeah.
Yeah. No, I know. So I did. When I made my picks, I was like, I kind of went chalk. I admitted sheepishly, and I think I had Bama in there. So I didn't go 4 first seeds, but it was enough. It was enough to get me the win. I did go with Florida winning it. Yeah.
Well, that's interesting. Yeah, I had Duke in the ones that I did. It just didn't pan out, but.
They were I shouldn't give away the secret, but this way I never take what I think is the best team. I take the best, number 2 or number 3, maybe number 4, because I feel like if they do win and they have a reasonable chance, you really have to beat a lot fewer people in terms of your picks leading up to that.
Right.
And this year
Well,
worked.
this is a guy who won. You got to listen to him.
Hey,
Yeah,
he got the secret sauce over there.
That's
He
my
knows.
strategy, and it works all right. But anyway, so let's get into.
Sure.
Also, wait, UConn women.
Yeah.
Them, man.
Wow.
Holy
Yeah.
crud!
Every
Crushed
game
them.
by more than 20 points
I
or
know.
something. 23
And
points or something.
They haven't won in a little bit, right?
Right, correct.
A little
few
bit.
Years.
Yeah.
I think
South Carolina was big
They won
for
it
a while.
last
Notre
year.
Dame, I think, won for
Right.
a while.
Yeah.
A dominant program, and credit South Carolina as one of like the premier programs, right?
Oh,
in,
yeah.
in women's
No
basketball.
doubt.
Philly's own, Dawn Staley.
Yeah,
Yep.
yeah,
That's
yeah.
right.
But all right. Sorry, let's get on with the show.
On to another sector of basketball. So yeah, I think we'll talk about Wembanyama first, which is interesting. One, because just from me reading it, I was like, oh wow, DVT in the shoulder. That's not something that you kind of hear every day. It's very rare.
Right.
And it was interesting in that at first they just said he had an illness, he was out for the game, and then a couple days later it came out that he had the DVT, and then he was going to be out for the season. And then also with that is another interesting little tidbit from probably like 2 weeks ago. An article reported that he underwent surgery, surgical treatment for the DVT.
Correct.
With the tea leaves, I have my own theories. I'm kind of very curious to hear your theories
No,
on
I
what's
mean,
going on.
I kind of know what happens and what the this is Paget-Schroeder disease or Paget-Schroeder syndrome.
Right.
He didn't have just a DVT.
Right.
So he had this effort-induced thrombosis, which is a classic sports medicine injury, and it's not exactly like what Damian Lillard has. Some of the same risk factors can lead to it,
Right.
but there's some subtle differences. Which
Tell
I'm
us
sure
a
we'll
little
talk
bit
about.
Oh yeah. Well, all right. Yeah. Should we get there already? Let's get right into it. Tell us a little bit
Go
more
for
about it. Yeah.
No, so I mean, there are every DVT has potentially causative factors,
Right.
right? So you have the hematologic causative factors, factor V Leiden
Right.
deficiency,
That's classic, right? Yeah,
activated protein C resistance, which is factor V Leiden.
Right.
You have protein C and protein S deficiencies, correct? And then you have the quote non-hematologic stuff,
Right.
being in a car for 10 hours, being on a plane ride for 6 hours,
Right.
So slow vascular flow.
Yeah. Smoking or contraception.
Correct, exactly. Or contraceptive, big thing for female athletes.
Right.
And then even things like bradycardia. So a lot of our athletes have, low heart rates, right? Because they're so
How
fit.
about that? Yeah.
They're so fit, and
Yeah.
so you don't think about stuff like that, but that can lead to more venous stasis. The blood's not pumping as
makes
I was not
as
aware of
strong.
that.
Yep.
All right. Yeah.
So a lot of different factors. We could start. The more simple one would be the Dame Lillard one, right? I mean, he's an NBA athlete.
Right.
They're traveling all the time. They're
Yeah.
on planes all the time.
Yeah,
They're
it's
sitting
gotta be
around
different.
all the right. And so, most likely, and again, we don't know, but most likely this is a non-hematologic DVT. And so that's why his prognosis is much better, and his prognosis to getting back more quickly is much better, right? So these patients are managed with, again, lower extremity DVT beneath the knee.
Yeah.
Right,
Which is
I
more
think-
worrisome. Oh no, not beneath the knee.
Beneath the knee is less
Not
worse,
beneath the
or
knee.
less
Yeah,
than
yeah.
1% of
Yeah.
those end up getting pulmonary embolus.
Yeah. But once it goes above the knee,
Then you get a higher chance of getting pulmonary embolus, which is the one thing that we don't want to have.
Right.
That's the bad thing.
Why? So what's that connection? And jumping right. What's the connection? Just for the layman, like what's the difference between DVT and pulmonary embolus? And then why is the pulmonary embolus? What happens with DVT? And why is pulmonary embolus so bad?
Sure, no, that's a good question. So the DVT, except deep vein thrombosis or the thrombosis, is the clot itself, is the formation of the clot. That clot's not necessarily a problem other than some pain and discomfort with the person having the clot in that localized space, so in the calf, for instance. The problem is if the clot breaks off and then goes back into the venous, this is a deep venous thrombosis. So the venous return goes back to the heart. It goes through the heart, the clot goes through the heart, and then bam, it goes into the lungs and gets stuck in the lungs. And that's when you have problems.
Yeah,
So,
pulmonary embolus. Yeah.
correct. And that's the pulmonary embolus, which lodges itself in the lung and then creates a very difficult situation for the person getting the pulmonary embolus, difficulty breathing.
Yeah.
A lot of the multi-system organ failure kind of shuts down.
Could
The
be
heart pumps against
catastrophic.
it. Catastrophic.
Yeah,
I think 30% mortality
Right.
with a pulmonary embolus.
With all, is it that high?
I think all cause, not necessarily in this situation,
Yeah,
but
yeah,
all
yeah.
cause it can be
I
that high.
I know, like saddle embolus, like the big one, right?
Correct.
That goes across. That's like the really worrisome one. I didn't realize the number was that.
Yeah, I mean,
high.
in older patients
Oh my
and
gosh.
patients who are infirm, that's obviously where the numbers are
Yeah.
higher. But it can be a a very serious.
And in the world of surgery, like we're always worried about this, right? Like because
Right.
you can take every precaution, still sometimes it happens, and like it's a very very scary scenario, and then that's exactly why. I think I guess 30% mortality rate, right?
Yeah.
Even still, like Dame Lillard, it sounds like more of your stereotyp. I don't want to say stereotypical because they're not
Right.
stereotypical
You're
for
right.
people who don't have these predisposing factors. Like it's
Correct.
still a little bit unusual,
Right.
but
Now, he
probably
may
more
have
easily
right.
treatable.
He may have a hematological under cause, and we're not going to find that out.
Sure.
But clearly, he's had a workup with our hematologists.
Yeah.
And, finding to see if he has something that's, and they titrate it into two different, or they space it out into two different categories. If he has the hematologic issues, antiphospholipid syndrome is another one.
Right.
Any hypercoagulable state. If he
Right.
has that, he'll be on
Blood
anticoagulation forever.
Right.
If they find that there's nothing,
Yeah.
and this is just something from, whether it be
Traveling.
traveling, things like that,
Injury.
then he'll be on hypercoagulability or anticoagulants for about 3 to 6 months until things have resolved,
Right.
and then not again.
Right. So provoked versus unprovoked. Is that
Correct.
what we're getting? Yeah.
Exactly.
Okay. Let's say there is an underlying hematologic disorder. There's a factor V Leiden, antiphospholipid. One of these things that sort of predisposes him to having blood clots, and thus he needs to be on a blood thinner, anticoagulation forever. Did his career just end?
No, actually not. And it's interesting. I started my young career off after my fellowship. I went back to Penn where I did my family medicine, and I did sports medicine there. And so we were taking care of some of the athletes there.
Yeah.
And one of our athletes had a DVT and had a factor V Leiden issue, but he was a football player, and he would be on his Lovenox during the week. On Thursday, he would go off his Lovenox.
Seriously?
He would play in the football game.
Seriously.
And started again on Monday. Yeah. So his hematologist gave the okay to do that.
Wow.
And I think he was a tight end. So,
Wow.
not a. Yeah.
Yeah.
So even in football,
Even in football,
you can find some, clearly
a
not the
workaround.
norm. But in basketball, even though it is a contact sport, maybe
Right.
not a collision sport, but a contact sport,
Yep.
I think he's going to be fine.
Yeah.
Based on the some of the newer anticoagulants that we have,
Right.
where we can control bleeding a little bit better.
It's much easier
Yeah.
to yeah.
Right.
Now, is there any role this might be getting over your head because you're not a hematologist?
I'm not a hematologist,
right? And
correct.
just to be very upfront and clear about that. Is there any role in that scenario, excuse me, for putting in a filter, an IVC filter, and again, it might be over your head. Like that's really getting in the weeds of a specialist in this field.
Right. I mean, that's somebody who gets frequent DVTs,
Right.
right? And you're worried about a pulmonary embolus. So
Yeah.
just for the viewers or for the listeners,
yeah.
there's an implantable filter that goes in and that captures the clots and allows the body to deal with them and won't let them flip up into the venous then cardiac circulation.
It's like a net in the big vein, the
Correct.
highway, the super highway back to your heart.
Correct.
to basically catch any blood clot
Right.
because it breaks off. So it can't go through the heart into the lungs.
Yeah.
But I think there are some risks, and I don't know what they are. Some risks associated with having that filter.
Yeah,
in
I
there.
don't
So
think if an athlete needs that, I'm
Yeah.
not sure that they're going to be playing at a high level.
got it.
That's
Yeah.
fair.
That would be my
It might be the end there. Yeah. Interesting.
Yeah, and I think historically with NBA and DVTs, I don't think they've gotten much. It's happened in recent history, but I know at least going back, the biggest name would be Chris Bosh. He kind of ended his
Right.
career.
Exactly
And
where I was going
that's
to go.
kind of where you were kind of when you're asking about ending his career. Kind of was oh yeah, I forgot. Like Chris Bosh had this issue.
Yeah.
And then to tie it into like what we mentioned before, traveling and other stuff, he tied it into.
He had a PE though. He had a DVT and then flipped the PE.
Yeah.
Yeah.
So
Right.
again, more like the Damian Lillard situation.
But it was arm, right? Like it was upper extremity, wasn't it?
No,
I'm
I
not
don't
sure.
think so.
I don't think
I
so.
don't think so.
I thought it was. I thought he was a shoulder or an
Was
arm.
it an upper extremity?
So-
Because it was not a Paget Trotter. It was not a effort-induced
Oh,
thrombosis.
you know what? You're right.
thinking about Brandon Ingram,
Yes.
who had effort-induced thrombosis, had surgery,
Yeah,
which we'll
that's-
talk about later.
I think
and came back and has
Stamkos
been
also.
playing.
Steve
Who?
Stamp, the hockey player, right? Like,
Yes.
I think he also
you might Be
did.
correct
And
with
so,
that too.
so you're right. It wasn't. I have it wrong.
Yeah.
You're absolutely right. It was not
Yeah.
Bosch.
And
Yeah.
I know Bosch, at least, he kind of was making a point. I don't know when I read. I think that was when we originally set up to do the show. I was reading about this history of blood clots in the NBA, whatever, and Bosch was one, and he credited too of like, yeah, we travel a lot. We're
Yeah,
always on
yeah.
planes. We're always
Right.
on stuff. And I think, I don't know, a few years back, I went to a sports seminar with one of the Lakers ATCs or PT ATCs at one point in time, and her presentation was on rest and recovery for NBA, and she just kind of put like this crazy graphic of the distance traveled between teams, right? And how like the teams who traveled the most were like on
more than Taylor Swift.
We're on the lower half of the winning percentage, and the team who traveled the least were was up there. And I think at that time, the team that traveled the least that year in her sample size of information was, I think, the 2016 Warriors, who ended up winning the whole thing. Yeah. And it's just crazy how that kind of died into it. But also, you figure they got a game in LA, they're going to Philly, Miami. Yeah. They're just traveling all over Toronto. They're going everywhere.
Crazy that's a risk factor, right?
Right.
Yeah, and I think it catches people off guard all the time. And sometimes, some of the surgeries that we'll do, we do a partial mastectomy, but it's surgery, and I don't want to downplay that, but it's not like open heart surgery. Like it's lower on the scale. And then people are like, oh yeah, but can I go to Florida next week? And you're like, it's probably not the best idea in the world,
right?
Because and people don't see it as a risk factor, but it is one of the risk factors for sure. The so we were saying wait. So Bosch is out.
Is similar to what Damian Lillard did, but Damian Lillard didn't have a PE.
Right.
Okay. So his is less severe, less serious.
Right.
And so the question is, does he come back, and when does he come back? So usually 1 to 3 months afterwards.
Right.
He's probably already conditioning, I would say, at a high level.
Yeah.
I don't know if they've allowed him to do contact yet, but that's the next step. And once he tolerates contact, and he may, again, he's on a blood thinner.
Right.
And he will have some bruisability, easier bruisability and things like that.
Right.
But, once things look good with contact, I think he comes back.
Yeah.
This is left field. Just coming out of left field. Right.
A lot of your questions do. Huh?
Yeah, of course. Yeah. I like it because I'm thinking about it different. Like, I'm pretty sure it was Ryan Clark when he played for the Steelers, wouldn't play in Denver because of sickle cell.
Correct.
And it's sickle cell trait. Does that play a role? Does that factor in or increase is that a risk factor for DVT possibly? And it's a little. That's what I'm saying. Traditionally, it's not really associated with that.
Yeah.
But is it possible, or is it?
I don't know the answer to that, so I'm not going to speculate one way or the other.
Sure.
Obviously, the oxygen carrying capacity when you're up at mile high is not as good.
Well, that's the concern for the sickle cell portion of it, right? You don't want to go
correct.
into,
But as far as the DVT, I'm not sure. Other than the travel to that area, I don't know of anything directly related to that.
So I do. I kind of want, and of course, as soon as these guys present with a blood clot, they get a full work. Not just these guys, everybody, right? Like,
right, yeah.
And again, one of the big, I don't know. I actually don't know that we touched on this yet. One of the other risk factors is if you have cancer, right? Like if there's something that's going on and you're not aware of it, it puts you at a higher risk. So clearly, there's a workup. As soon as why did you get? If there's a very obvious reason, you just had surgery, you were immobilized, unfortunate luck, whatever it was. But if there's no clear-cut reason, they get this full workup, and I don't know. It is an athlete thing. I don't know. It's an
but I think the good news also is that this is easily diagnosable.
True.
Right.
Yeah.
If
So
you think
easily.
about it and you keep it on your differential, and obviously Damian Lillard had some calf pain, I would think. And that's the first thing we're taught to think about in the medical field, right? Is this a blood clot?
Yeah. As soon as the red flag goes up, boom.
Very easily diagnosed. You go for an ultrasound, which is a 15-minute test.
Yeah.
And bam, you either have it or you don't.
Yeah.
Very simple. And even with Victor Wembanyama, again, he presented with fatigue, malaise, and then a little bit of achiness in his arm.
Right.
Yeah.
Right. So you think about that. Usually the effort-induced thrombosis is associated with some swelling in the arm. So then you have to start thinking about that. But again, an upper extremity ultrasound finds it 15, 20 minutes.
Yeah.
You got your answer.
Yeah. It's pretty unusual for an upper extremity DVT, even if it does become a PE, to be fatal. Like
much less so than a lower extremity.
Yeah.
Correct.
Not impossible, but so you still, of course, take it very seriously. But super interesting. Far less common for people to get a DVT in their upper extremity.
The most common for people who are athletes, that's the lion's share of the people who get upper extremity DVTs and this Paget-Schroeder effort-induced thrombosis. Right?
So tell us a little bit about
athletes.
What's going on with that.
Right. So there's two different things that are going on. So you have that hypercoagulable state for the things that we mentioned, travel, smoking, maybe bradycardia, maybe injury and not working out as much.
Yeah.
causing that. And then you have in the upper extremity with people who are overhead athletes. So most common baseball players, obviously.
Right.
Weightlifters, swimmers, those are like the three most common. But then football and basketball right after that, because there is some overhead stuff with both of those.
Sure.
There is a component of a compression that occurs in and around the subclavian vein.
Right.
And between the clavicle, first rib, and then the other borders in the chest, there can be some compression when they do overhead activities in and around that subclavian vein.
Right.
Can not only cause blood flow to be restricted, but can also damage the
vessel.
blood vessel.
Yeah.
Right.
And that is Paget-Schroeder syndrome or effort-induced thrombosis.
Right.
And you figure, you're talking about someone, his Wembanyama's job, or not his job, well, it is his job, but I mean, he's known for blocks and his arms are always up and they're super long, big, lanky guy. So it's something that's very common for that.
So the other interesting thing about this, that people look at studies and most of the time when it's reported, it's in the dominant arm. Right. The interesting thing is the right way to block a shot.
Yeah.
If you're going up against a right-handed basketball player, me being a frustrated basketball player, is to use your left hand as a defender to block a righty shot because that's the easiest way.
Makes sense.
I went back and looked at footage of Wembanyama. He hardly ever blocks with his left hand. He blocks with his right hand, which is where he has the clot.
How about that, man?
So you got to stick to the fundamentals.
Yeah. Exactly. Although he could have had the clot in the left hand if he'd done that, but who knows?
That's actually an interesting point, and definitely
I think it's a very interesting point. Yeah. Now, how does that differentiate from thoracic outlet syndrome, which is a whole nother sort of crazy entity?
So Paget-Schroeder is thought, in addition to being the effort-induced thrombosis, it's thought to kind of be in the same category as thoracic outlet syndrome.
Right.
It's not like most people who get thoracic outlet syndrome, but it's part of that because of the compression at that site.
At that same sort of level.
Correct.
Yeah.
And so what they found is the best way to treat this, obviously the earlier the better, is to do anticoagulation, right? Is then to try to get the clot, either dissolve the clot locally or thrombectomy, remove the clot. And then a thoracic outlet syndrome surgery, which is a resection of the first rib.
Yeah.
Correct.
Yeah.
And to make more room for that large vessel to move unobstructed.
So pretty classically associated, but although definitely not like mandatory, is cervical first rib. Right? Like you have an extra rib, and then like that's kind of classically, especially on tests, right, associated with thoracic outlet.
Right.
Does that hold true for Paget-Schroeder?
That they have an extra rib?
Extra cervical rib.
No, I don't think so.
So it's a little bit of a different end.
Correct.
And oftentimes in thoracic outlet, I'd say the majority of the time in thoracic outlet, they don't actually have an extra rib. But
correct.
That's like traditionally test-wise, that's the
That's
affiliation
what
we
they
make.
talk about,
Yeah. So even if you don't have the extra cervical rib, the treatment is remove a portion of the first rib.
Correct. Now, listen, if they're not a professional athlete, you try to minimize harm and you try to do the least invasive thing that you can to have them recover.
Yeah.
But if you only do anticoagulation, there's a 44% risk of re-thrombosing, recurring. And if you do all the measures that we talked about, it's less than 2 or 3%.
Yeah.
Right.
Yeah.
And I mean, he's very young in his career still, and he's going to be the face of that franchise for a long time to come. So they got to make sure he's doing what's right for him in long-term health and all that stuff. So that makes sense.
And again, we mentioned that Brandon Ingram, maybe 5, 6, 7 years ago when he was with the Lakers, had this done, and he's had a pretty great career.
Yeah, he's done well.
Afterwards, he's done fine. Yeah.
He had the procedure?
Yeah, he had the procedure as well.
So it's like what always comes to mind for me is Matt Harvey as a pitcher.
Yeah.
But it was thoracic outlet. As far as I know, it was thoracic outlet.
It was thoracic outlet because he had numbness and tingling as well.
Yeah. And I'm guessing then, the artery is actually a little more involved in that particular part. But really, honestly, the vein can be, with thoracic outlet, can be purely venous too. But like, he was never the same. Like he was never the same after.
Even after successful procedure. Right. He was never the same.
And Wembanyama, he did undergo surgery,
yes,
right? Yes. We don't have access.
We don't know exactly.
We don't know what he did. We don't have access to his medical chart. We're just
But if he underwent surgery, there was definitely a thrombectomy of some sort.
That's my gut. Is that was thrombectomy?
Right. But I do think also that he had a first rib.
You think they did it?
I do think so.
Yeah.
Yeah, I mean, you got to go for the gusto and get it done, so you don't have to go back in and have any more
Correct.
issues.
Right.
Correct.
I don't know. I just feel like his anatomy, right? Like he's just so big, long, and lanky that
Right.
I'm sure that first rib is much larger than the average human. You know what I mean? It's probably a pretty long rib.
And he's a fairly slender guy.
Yeah, very slender.
I wonder if that also, I can't imagine it does. Does that contribute in any way to
Like body type, you mean?
Yeah,
Just like-
yeah. The length, the slender. Yeah.
I mean, listen, you're talking about a guy who, as you know, as we say in the sports medicine lexicon, has Marfanoid features.
right,
Yeah.
right.
Right.
So he does
So
look like
similar
that,
to
right?
Marfan syndrome.
100%,
Very,
yeah.
very long limbs, very flexible. It seems like.
Mhm.
And so people who have Marfan syndrome, a connective tissue disorder
Right.
in the aorta that thins the aorta. So, again, does that have something to do with his
boy,
cardiac
he's going down
stuff?
a whole different
But
road
listen,
right now.
the guys in the NBA,
Yeah,
because Marfan's is associated with tall,
Yeah.
they get scanned,
Check.
they get
Yeah,
echoes every year.
Yeah.
They're very, very well looked after. And so clearly he doesn't have this, but it's something to think about,
Right.
as in that kind of patient population.
And honestly, like this, like the sky's the limit with that guy. Like he's a good ball player.
Yeah, he's great.
Yeah.
Yeah. I mean,
Really well.
yeah, and it's it would be, I hope it doesn't negatively impact him. It's nice to see that it's been a precedent, right? Like
Yeah.
other people in the league.
And
have
Brandon
had it.
Ingram, to be honest, has the same body habitus as him.
Right,
Yeah,
right.
no.
He's thin,
Yeah.
slender,
Yeah.
Mhm.
7
Yeah.
foot tall.
Is he
kind of
that
thing.
tall?
Yeah, he's 6'11", 7 foot. Yeah, pretty
Yeah,
big
he's
guy.
pretty tall guy as well.
Yeah.
And I think to go back to what you said about how like they're in the NBA, right? They're already past all this stuff. I forget who his name is, but I don't know, probably like 8 years or so ago, there's someone was coming out of college, and I think he got diagnosed with Marfan syndrome in the draft, like in the
Yes, it
setup.
was a Baylor
Yeah.
athlete.
Yes. It was. Yeah, I was going to guess
All
Oregon,
over it.
but I just guessed Green School. Was how my brain functioned. Now I was like, it's a Green School, right? But yeah, same thing. It was like he got diagnosed with Marfan syndrome, I think, in his physical leading up to the draft or something along those lines. And I think he got it's like someone drafted him for a one-day contract,
Correct.
signed him or something like that.
So he would get the health benefits, healthcare benefits.
Yeah. So it's definitely a thing and happens. And, these athletes who are really tall and long and lanky, that they can be fine all the way up until it's not. And then you figure it out on a physical or something like that. And then ultimately kind of save it from getting worse.
Yeah, I mean, this dovetails into a whole another side
Yeah.
of sports
Oh, yeah.
medicine about
100%.
screening. And, we're looking for sudden cardiac death in athletes.
Right.
And so that's why we put them through all this rigid screening process. And
Yeah.
and even though they might not have anything at 18 or 20 or 24, they've even done studies to show that high-level athletes, even up to the age of 40, can still then develop these syndromes. Again, we're getting a little bit off topic.
Sure. No, but it's all good stuff.
Can still develop, cardiac abnormalities that can lead to sudden cardiac arrest. So that's why we have to be very vigilant
Yeah.
about this.
What do you think it is that someone at 22 years old or 23 years old doesn't exhibit any of these symptoms or any of these issues, and their body may not change a whole lot, right? The bone structure isn't changing a whole lot. Maybe put on a little bit of weight, but for the most part, but then 5 years later, all of a sudden they develop this exact this issue. What
I
changes
think-
in that period of time
yeah.
that all of a sudden they develop it later?
Right.
I mean, it has to be a perfect storm of a lot of different things.
Right.
Right. So it has to be that hypercoagulable state that we talked about.
Right.
It has to be that overuse. So, obviously when he came to the NBA, he wasn't working as hard as he is now.
Right.
Right. And so he had his first year kind of feeling things out. Second year, he wants to do more to improve himself.
Right.
Maybe he's putting in more time. Maybe he's lifting more weights. Maybe he's doing more overhead activities. And I think that with the hypercoagulable state, I think that was just the perfect storm.
Yeah.
Or you insert the Olympics and he played basketball
Yeah,
all
he
summer.
did.
You know what I
Correct.
mean? Like you
Yeah.
just
Good
put that
point.
into it.
Valid.
'Cause
Yeah.
That's I just think of like, why is he playing more basketball? Well, the Summer Olympics, and he was playing for France. And,
Yeah.
and I think actually the reports of his surgery and stuff came out from the France.
From the French
French-
doctor,
Oh, is that
or the
right?
French coach.
Yeah,
right.
the French coach was
Right.
talking about it, and I was like, oh, that's different. Like at first I was expecting San Antonio to be the one, but obviously I
Mum's
guess
the word. Yeah.
Well,
Yeah.
there's
Yeah.
a big world basketball tournament, the FIBA
Yes, the
2025.
FIBA,
this
this
coming,
summer,
so
yeah.
they wanted to know if he would be available for that.
Yeah, so and I'm curious what they say. Prior to injury, he was on the roster, and they plan to have him if he's available. So
Right. A
with-
French team, man,
They're good.
Like,
They've always been good.
Right,
Great team.
yeah. But like if I think the U.S. tradition has been thought of like kind of the best basketball team, the
Yeah.
best basketball country, and France is challenging. Like
France,
it's legit. Yeah.
Who Who else is really good? Australia's usually pretty good.
They're always very good. Yeah. Spain has had
Spain's
a
a good
the
team.
Lithuania, yeah.
Right. And now some of the Eastern Bloc or the former Eastern Bloc countries,
Right.
Serbia,
Right.
Slovenia.
Yeah.
Yeah.
Put together some pretty good teams.
Yeah, for sure.
But I feel like the one that really, really challenges is France.
Yeah, I mean, they're definitely the number 2 right now.
Right.
Yeah, for
Right.
sure. So with that being said, right? So what's our?
Sorry, we forgot Canada. We can't leave Canada out.
Yeah.
Right, they have some really good players, right? Shea Gilgeous-Alexander,
Yeah.
Uh-huh.
right? So they've got some nice
Yeah.
talent,
Can't
too.
argue with that. Yeah.
They're on the come up for sure. So what are your thoughts on his return to play? I mean, he got diagnosed and was told that he was out February 20th. It's now April 8th. When does he return? Obviously, he's out for the season, but going in next year or even in the summer for the FIBA tournament that we just mentioned.
Yeah, I don't think he'll play in the summer tournament.
I can't imagine he would.
Yeah,
there's no way.
Exactly.
I mean, I think it's reasonable to get him back for the regular season or maybe December of next year.
Is this when I hear this, when I hear that, like, oh man, blood clot in his shoulder or blood clot in his arm, I really honestly, I say, like, career-threatening injury. Like I can't imagine with the possibility of this being a career-threatening injury. Not and hopefully he gets back, and probably he gets back. But with that sort of hanging over your head, I just can't imagine he's going to go. And
Yeah,
play,
I agree.
Right?
Yeah, that makes sense.
And
I think, I don't know financially what France does for you playing on the national team, but
I'm
I
sure he
think
loves to play for
I'm
them.
sure he does,
Yeah.
as a personal thing, but I'm pretty
Yeah.
sure the paycheck from the San Antonio Spurs outweighs
Kind of
what France does.
driving the decision
a little
making.
bit there, right?
Yeah.
But I think going forward with it, it fundamentally could make him a better basketball player if he's not using the correct hand to block shots. And
Listen,
he might
I didn't say that. I'm a sports medicine physician. I'm
Right.
certainly not a basketball coach.
Let's see if we can get you out there, work with him on some of his basics, make sure he knows what he's really doing.
just to work on his block percentage. No.
Right.
But no, I mean, it could work if it was the same thing of like now he's not, he might be more hesitant to use that right hand, use his left a little bit more. Could change that a little bit. So we talked about him. So now with Damian Lillard, we talked, more lightly about like, oh, he should be coming back sooner or whatever. And, as of this morning when I was reading over just some general articles, it's much more of a positive outlook. It's like, oh yeah, he's going to come back when he comes back. He's already been doing some stuff. All his tests and stuff are looking hopeful. Everything's all positive news.
Right.
Obviously, no definitive timeline, but I think there's a chance that he comes back in the realm for the playoffs or something along those lines. At least Milwaukee's coach Doc Rivers was just saying, like, yeah, we're just trying to figure out how to play without him just in case, but hopefully we're having him back and we know what we're doing when he's back on the floor.
Right.
So, what are your thoughts on when he may or may not return? I think
pretty traditionally the number is, and I would defer to Dr. Webner, who knows this better than I do, right? Like, but I think pretty traditionally the number is 3 months, right? If there is not an underlying additional cause, right? Like there is no coagulopathy, or actually I should say, like clotting disorder, where he's prone to develop blood clots.
Right.
If there's no underlying condition, like they do a workup, there's no signs of cancer. He's not a smoker. He doesn't have any other risk factors and whatnot. I think pretty typically 3 months of anticoagulation, and that's, I think, the lowest that it goes. It's usually 3 to 6, like you said. But in the best case scenario, 3 months of anticoagulation, get him back, get him playing again, provided. And I would imagine, I don't know for sure, but I would imagine on that level, they're going to do follow-up ultrasounds and make sure that.
Serial ultrasound.
Yeah. Exactly. So, what was the date when he first was?
I think
pregnant?
the report I noted down was from 3/25, so that's about 2 weeks ago. So we're not even a half a month out
We'll
of.
See you next year, buddy.
Yeah.
I can't foresee a scenario in that he gets back at the end of the season. He gets back in the.
Yeah.
I mean, the playoffs go long, but I would be surprised.
It'd be one of those.
What are your
it would
thoughts?
be pretty shocking.
Yeah.
It'd be one of those like Brandon Graham type stories of like you maybe
Right.
get him back for the finals
Right.
if you're lucky.
Right.
If you really want to push it and you got everything signed
Like
off.
Terrell Owens.
Yeah.
Right.
His fracture coming back.
The epitome of sports medicine when you make those hard championship decisions, if you will.
Right, we talk about Brandon Graham, right?
Yeah.
Like he's gonna do it. He's got it. It's a Super Bowl. Like I don't know if this is a great idea. Retour. Like, but they won.
He played
Like, he was
great
part of
too.
it. Yeah. So that's the risk he was willing to take.
Yeah.
And he took it. He went for it.
And I mean, he got it one more time on the field, and
Right.
after that, he fixed it again, and
Yeah.
he's on his way to do his retired life. So
Yeah.
sure,
Yeah,
go
yeah.
for it.
Although fixing it again doesn't usually work as well as fixing it the first time. Yeah.
I'm sure it did not look good in there. That's for sure. So anything else to touch on about the DVTs and the all these different things that we kind of.
No, but I think that was spectacular
Yeah.
information. I do want to talk about this other thing that we just saw last night that we
Yeah,
sort
yeah.
of slapped onto the.
Yeah, so we added one little quick thing, and I think I've gotten accustomed to anytime I see something on social media or on the internet, and it's reported as a rare injury. I'm like, oh, I should definitely bring this up on the podcast kind of deal. So I believe it was yesterday, which is April 7th, because as we mentioned before, we record on Tuesday, it comes out on Friday.
Yeah.
The Seattle Mariners outfielder Victor Robles ran into
Speedy
the outfield
guy.
wall. And he ran into it hard.
Yeah, that guy
Yeah.
can fly, and he was going. Looks like
And
full
he
speed.
was full F6, whatever it is.
Yeah.
He was going full tilt into
Yeah.
that wall. Made the catch, and I will make this point that he made the catch. The catch was challenged, and it reviewed and it stood up that it was a catch.
Yeah.
But in the process of catching it, the one report and video that we kind of looked up is a rare video because of a shoulder dislocation, and per an X-ray that they showed, it looked like he had a posterior shoulder dislocation, which is the rare part about it.
Yeah,
And then
far less common.
Yeah, far less common than what's typically seen as like an anterior dislocation, which we've talked about. I think I'm sure plenty of times.
Yeah.
Probably what Shohei Ohtani had, which we talked about last time.
Sure. One more subblocks, but yeah. All
Right.
Yeah.
So to talk about that, we can dive into that and kind of go from there.
So yeah, what's the difference between anterior dislocation and posterior dislocation?
All right, am I back in fellowship?
Yeah. No, you're explaining to the guys that are still waiting to get in.
Right. So the anterior dislocations are far more common, as was mentioned. 95% of them, shoulder dislocations are anterior, and really it's the positioning of when the person dislocates the shoulder or subluxes the shoulder, and usually it's in an external rotation, and then there's basically the femoral head kind of pushes through, and that's why it's the most common. Occasionally, you'll get a posterior dislocation like this. It's usually from a really high impact trauma.
Yeah.
The most common, or the test question is somebody's a passenger in the car, or
Right.
they have their hands on the steering
Yeah.
wheel.
Yep.
They have a front crash, and then the femoral head goes out. Sorry,
Humeral.
the humeral head.
Yeah.
Humeral head goes out. You'll have to change that.
Yeah.
Humeral head goes out the posterior aspect
Right.
of the glenoid, which is the socket of the ball socket joint.
Right.
Yeah. And I mean, like you mentioned, I would categorize that run into the wall like up there with a lot. Not obviously with a car crash, but I mean,
He hit it
was
hard,
going
man.
full tilt, hit and the video that I sent you when we showed pre-show. I mean, if you turn the volume up, you can hear it in live and just the impact. It sounded like it was a football game, like a big football, hit across the middle or whatever the case was.
Yeah.
And he made the catch, went down, and then his arm was just hanging for a minute. And
Right.
I think what I read briefly that they may have reduced it on field, and then they sent him for imaging and other things like
course.
that. So
So it was interesting, though. He was in an external rotation position initially,
Yeah.
and then he hit the wall. And I
Right.
think the hitting the wall was the thing that
Pushed
created
him
the
back.
posterior.
Yeah, posterior.
And it was a
Translation.
little strange. Like his arm was up when he hit it. It wasn't like
Out.
out.
Correct.
Usually it's this, and it drives it out the back, like you're saying.
Yeah.
But his arm was up. It still did the same thing. It drove it out the back, but it
Just
was
a
up
weight,
in the air. Yeah.
I think if I remember correctly, he like kind of hit a fence and kind of tilted over, and I'm sure that changed physics and all that stuff. Just
Sure.
ended up coming out the back, and this was like, oh, that's definitely a little different
Right.
than like we mentioned, and I think we've covered
You see
plenty of times.
The positioning of his arm when he does get up, like he pulls himself out of the little, from over the wall,
Right.
and he's got, the ball is in his glove, and you see him just
Dangling.
just drop the ball out.
Mhm.
But lots of times when someone dislocates, when they go out the front, it's kind of this position,
Mhm.
and he's in this position, which
Yeah.
is how they go out the back. So, like you see that, it's a little bit of a tip off.
Right.
I think also really, really important for these particular injuries is that oftentimes they look normal on the X-ray, the standard X-ray that we do with an AP, and so this would go more to like the kind of the medical personnel out there. Pretty standardly, they go into the ER, they get 3 X-rays. They'll try to do an X-ray and AP like from the front, and they try to do it with the arm and internal rotation, if you can, an external rotation, and then they do one from the side. And lots of times they don't do what we call an axillary or a lateral, like where you're looking at it from the top down or bottom up, or strike it. There's a few different names for it.
Right.
And when you're looking at that AP, so story time. I was a resident. I remember post call. I was a resident, and when we like post call last time, we'd go to office hours and be in the office with whatever doc all day, and then you'd go home after that. So it's post call, and I remember I got in my car and I'm getting ready to drive home, and I got a call from one of the junior residents, one of the younger residents, a guy Kevin McDade, awesome guy. I think he practices up in Lehigh Valley now, hand guy. And he's like, listen, like I'm in the ER and there's this guy with his shoulder pain and like he can't move his arm. Like it looks like it seems like he dislocated his shoulder. He's like, but the X-ray looks normal. And I'm in my car, and this is before we had like cell phones. You could take pictures and send like
like picture messages,
HIPAA compliant images and all that other stuff. And I'm like, he has a posterior dislocation. And he's like, I'm looking at the X-ray, and it is normal. I'm like, he has a posterior dislocation, and like this went on for like 5 minutes. like I'm telling you, he went out the back. Like you got to get the axillary lateral. He can't. His shoulder hurts. Have to get the axillary lateral. And technically, they could have done the CT. There's a couple of, but then sure enough, posterior dislocation diagnosed like from the car, and so you just need to be aware of it because it will see you as a medical professional. Mm-hmm. It will see you, and if you're not aware of the fact that AP that standard view is going to, for the most part, look normal. If you're not aware of that, you're going to miss it, and then that leads to bigger problems down the line.
So the other thing I will say, just I know this is a sports show. But there's also, and I just remembered, Parkinson's patients oftentimes have a posterior dislocation.
Right.
Because they fall and they can't stabilize themselves, and they will have. That's the other test question for posterior dislocation.
The other test fodder would be electrocutions.
Correct. Yes.
Electrocutions. Right. The muscles in your back are more powerful than the muscles in the front, and it pulls it out the back. This is like test fodder. Like this is just This is what they throw at you. So if you're getting ready for your boards, you're getting ready for whatever test, USM, whatever the test is. Like those are the different things. When the test writer is setting up your question, that's what they put in. That's your clue to know. If you don't know it, that's an important factor you're supposed to know. Yeah.
So Dr. Frey, I would ask now, what is his prognosis based on a posterior dislocation versus an anterior? Yeah. And clearly he's not a pitcher.
Right.
Yeah. And this was his glove hand.
Yeah.
Is that correct?
I believe so.
So it's not his throwing hand. So how would you manage this athlete if he came into your office?
It depends. We get an MRI. He's going to get an MRI without question, right? And if there is a pretty decent sized labral tear, I'm probably operating on that guy right off the bat. If there isn't, I'm going to treat him conservatively. I'm going to go non-operative physical therapy, give it time. If he goes out again, yes. So for a young individual, right, for a young guy, someone in their early 20s or under the age of 20, it's high. It's like over 90% that they're going to redislocate.
But again, that's anterior, right?
With anterior.
Right.
But with posterior, it's a little lower than that. Right? I don't have the exact number, but it is definitely less likely. But if they knocked off a big piece of the labrum, I'm probably just going to go in and fix that. Especially, granted, it's his glove hand, but it's a high-level athlete who's going to have this one particular, and he's also like a base stealer and he's sliding into the bag and all these other things. And so I'm going to have a lower threshold to go in from a surgical standpoint and fix it. If it's your average, everyday individual, especially if there isn't a big level tear, I'm going to wait and see. There's no harm or very little harm. It's possible to dislocate again in the meantime. But assuming that they don't have another dislocation, I could do it tomorrow. I could do it in 6 weeks. I could do it in 3 months. I would still expect the same good outcome when it's all said and done if I went in to fix it. And there's a pretty reasonable chance that the pain's going to go away. They're going to start to feel stable, and they're not going to have another problem again. So if that's the case, give them a chance. Try to do a non-operative if you can, and then don't do it. But in this guy, in this sort of level, this high-level athlete, if he has the labral tear, you're going to go in and you're more inclined to be aggressive and go in and fix it right off the bat.
With his caliber, what he's doing, and obviously, if you see the video and you can just appreciate his athleticism, the guy's super fast. And that high speed with force of sliding into a bag, running into a person, running into a wall.
Right.
You don't want that thing to come out again.
Yeah.
Or, you don't want to run into that risk long term.
So provided there's no cuff damage,
yeah.
right?
Yeah.
There's no bony reverse Bankart or reverse.
That changes everything if it is. Yeah.
And you repair the labrum.
Yeah.
When can a guy who's a non-thrower or is his non-throwing arm, when can he come back?
I think it was 4 months.
4 months.
Yeah.
So maybe near the end of the season.
Potentially, yeah. So I say 4 to 5 months. Usually, I will not let them back in fewer than 4 months because there's a fair amount. And if they're doing great, and lots of times they do, honestly, they just do well.
This is specifically posterior dislocation? 4
No,
months?
no, this is just labrum in general.
Labrum in general.
Labrum in general, yeah, exactly. And even that would also hold true for something called a Hagel tear or Hagel lesion, which is similar, creates instability, except
It's the capsule.
It's the capsule where it attaches to the ball as opposed to the labrum where it attaches to the socket. Basically sort of the same structure for the most part, although the labrum's like thickened and whatnot. But it's the same structure, just the other end of it. But yeah, typically I say not less than 4 months, oftentimes 5
Even
months.
if they're not, even if that's not their throwing arm.
Yeah. I just don't want him to slide. I don't want him to fall on it. I don't want him to take a hit. It's just too tenuous. It has soft tissue. It's just too tenuous at that point. Yeah.
And I think with that too is his being an outfielder, he has to have like
He has to
the
dive. He has to
range of motion, all that stuff. It might be a little inhibited at that rate, or
Yeah.
and I also think what I thought about this too is with all that being said, everything's fixed, surgically, whatever. I think there's going to be it could be a psychological component as well. Next time he tries running into the outfield wall, like,
Right.
oh snap, am I too close? Like it could be, a
that'll
sports
be a
psychology
factor.
thing.
Eventually he'll get over it.
Right, eventually,
Yes.
but I'm sure
Or he'll get help.
that
One or the other.
first one that he goes towards that wall is going to be probably a little scary for him.
It's like reaching out. Where is it?
Right.
Well, they can put him at first or second base for a while.
Right.
To avoid that.
If need
But
be.
Exactly. And well, it's not his throwing arm. You could save his arm because he has to make throws in the outfield, but it's his glove hand. So
Yeah.
see what that goes.
Have they announced? Has he had surgery? Have they?
I don't
this
think
was
so.
this was a pretty brand new injury.
Yeah, we'll do a live Google search.
little live update. Yeah.
Let's see.
I imagine the MRI happened today, if not tomorrow.
Yeah, I mean, they
MRI
put him on the 10-day injured list. So
That would be fast. That's a pretty positive indicator.
oh, wait a minute, we got 4 hours ago. He has a fracture in his
hot off the
Shoulder.
presses.
Yeah. So I'm
to miss at least 12 weeks with fracture.
That's
Yeah,
a
they're gonna
reverse.
fix it.
That's
It's
a
a
reverse
reverse
bank
hand.
card.
Small fracture in the
Bank.
humeral head of the left shoulder.
Yeah.
He'll miss
Oh,
about
humeral
humeral head.
head.
So maybe it's a Hill Sachs. Or do you think it's a greater tuberosity fracture?
Oh.
That's really odd. Small fracture humeral head. Because if you go out the back, you don't get a Hill Sachs. A Hill Sachs, when you go out the front, you get the dent on the back of the ball.
Right.
So I wonder if it is greater
You can't get a
tuberosity.
reverse. Is there a reverse Hill Sachs?
I think there is.
Mhm.
It would be pretty unusual, but it could be that. But that wouldn't warrant surgery unless it's big, right? Especially that. Like that's
I wonder
such
if
a
it
weird thing.
actually just
I wonder if it's
fractures
greater tuberosity, or I wonder if it's actually socket and they got it wrong. It's
Right,
actually the
right.
glenoid.
And this
Yeah.
is just an ESPN article that
Yeah.
came out about 4 hours ago. So
The most likely thing is
I
he
think they
knocked
got
off
it
a little piece of
wrong.
bone.
It's probably glenoid.
Yeah, exactly. In which case, he's probably headed for surgery.
And so what we're talking about
said
here,
3 months?
when the ball sits in the cup,
Yeah.
the glenoid is the cup.
Yeah.
All right. The ball is the humeral head.
Yeah.
And what we're talking about is most likely a fracture in the glenoid as the ball comes out
Knock
the
it out.
glenoid and,
Right.
and knocks the bone.
yeah, so per this article, and just I think it's more of a PR standpoint, right? They just said they're going to monitor for the next 6 weeks to let the bone heal, and then he's going to rehab for another 6 weeks after that.
If it's non-displaced, although I'd be surprised if it was non-displaced, but if it's or if it's minimally displaced, less than 2 millimeters, even that, I don't know, man. I'd be a little bit aggressive. Maybe they can non-op it, and if it heals without surgery, it is a quicker recovery. Like get him back a little sooner.
I'm glad we looked that up. 'Cause that's
Yeah,
way
yeah.
more, a little different than just the dislocation part
Yeah,
of it. So.
the devil's in the details. We say
Yeah.
that all the time. Like it really depends on what it looks like. And I'm sure he has an MRI, and I'm sure he also has a CT. To be honest with you, that gives you better
Right.
definition for the bony architecture.
Yeah.
Well, that was a good and little tidbit there.
I like it.
Anything else while we're here? We still
Yeah.
have a little bit of beer left. Anything?
Oh, good, man.
Go Phils.
Yeah, for sure. They're up 1-0 right now. So, Dr. Webner, thank you for coming out. We appreciate your time.
My pleasure.
It was a good one.
Welcome.
Happy to
welcome.
come back.
Oh yeah,
Yeah,
we'll definitely have you
Oh yeah,
back.
yeah.
And then we'll go from there. And then before we go ahead and close out our tab, we're just going to give a quick shout out to our sponsors. Virtual Orthopedics and Spine, from runner's knee to dog walker's hip. They got a doc for that. Yard work, back, and laptop wrist. They have a doc for that too. Virtual Orthopedics and Spine has over 120 providers, over 20 PT rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtua.org/ortho.
Did we mention Sourfest again?
We will now. And our good friends at Neck of the Woods Brewing Company, as always, serving us up the best beer in South Jersey. And with Sourfest around the corner, Sourfest is here. It's May 17th.
Yeah.
Here at Neck of the Woods at Total Turf in Pittman, New Jersey. Tickets actually go on sale April 10th, which is when you're hearing this yesterday, because we're releasing the show on the 11th.
Right,
so
right.
They're going to be out
They're
now.
on sale.
They're on sale now. So go ahead and get them. Check Neck of the Woods social media and get all the information, and you can be able to buy your tickets for that. It's a great event. Last year there was a great outcome. 2 years ago I think I came here. It's fantastic.
I was here last year.
Yeah,
it was awesome.
Yeah. Maybe this year will be the year we actually record a show from Sourfest.
We talk about it all the time.
We talk about it every year. We haven't done it. And lastly, to give a shout out to Timber Road Production, helping us get all this information out to you and the video and all that stuff. So give us a follow on YouTube and Instagram, and we'll see you next time, folks.